Hi, my name is Norina Allen. I am an associate professor in the Department of Preventive Medicine and the chair or the director of the Center for Epidemiology and Population Health within IPHAM. I'm very excited to welcome everyone here today for the first inaugural NUCATS IPHAM lecture. As many of you know, the IPHAM seminar series has been a long-standing series, and this is the first of a monthly jointly sponsored series with NUCATS. We're excited to welcome Dr. Nicholas Soulakis, who is an assistant professor of preventive medicine in the Division of Health and Biomedical Informatics and Epidemiology. He's also a director of data science services at NUCATS, and he currently is serving a role as an epidemiologist in the Illinois Department of Public Health's Division of Health Protection, and is helping to lead contact tracing efforts across the state. So we're excited to welcome you here today, Nick, and I know you're going to do some introductions with slides. I did want to let everyone know that if you have questions to pose to our speaker, please enter them in the Q&A, not the chat section, but the Q&A panel, and I'll pose those questions to our speaker. Nick, take it away.
Great. Oh, thank you so much, Nori. I'm really excited to be here. This is a great opportunity. It's a really great idea too that NUCATS and IPHAM got together to do these translational applications, because I feel like these days everyone's translating their science to the challenges we face, and I'm no different. So I really appreciate the nod from both NUCATS and IPHAM that I could give this talk, because I do indeed translate my science every day. So largely what I'm going to be talking about is public health practice in the time of COVID-19. Just to get started, since Nori did that fantastic introduction, I don't need to say where I live in Feinberg. But today I wanted to talk about some things just to sort of get us focused and centered. Not everyone understands exactly what is informatics. So, and to be fair, I do a different, I do my own kind of informatics. So I'm going to say what is informatics, and what are public health informatics, and who are public health informatics users. What are the kind of workflows that lend themselves to public health informatics? How do we improve with those workflows with public health informatics? And lastly, I think a lot of us are relying on metrics right now to get through the day and organizationally. And so I'll talk a little bit about metrics. This isn't meant to be an exhaustive talk, but I did want to see the Q&A a little bit. Nori and I have worked it out that, as questions come in, if they are pressing questions, I'm happy to take a pause and answer a question, or we can, we'll have plenty of time at the end. I don't plan on talking the entire time. Of course, I'd like to leave questions for time for questions. So just to get started, a little bit about me. I am trained as an epidemiologist, even though I live in the Division of Health and Biomedical Informatics. Northwestern's really fantastic and unique in this, in the sense that they have both informatics and epi in the same department, which organizationally is really great. And there's a lot of synergy there. So Northwestern's always been a great fit for me. Nori already talked about my NUCATS and Feinberg roles. And it's true these days I'm an epidemiologist in the Office of Health Protection at the IPHAM, where I've helped to develop and grow the contact tracing program, and but really I've done, as we all have, I've taken on many roles throughout the last 6 months, and to say it's just all epi is probably a misnomer. And most recently, and this is hot off the presses for this seminar, I will be working with Chicago Department of Public Health as the Chief Public Health Informatics Advisor on some of their really, I would just say, evolutionary informatics infrastructure that's going to be rolling out for the city of Chicago. And I'll be helping to form an informatics strategy for CDPH. So look forward to working with CDPH and with my colleagues at Feinberg for their good advice. So just to get started, we're going to talk about informatics. Those of you that are furiously Googling the definition of informatics, there's many. I like this one, the science of how we collect, organize, and use information. And I attribute that to my good friend and colleague, Dr. Justin Theron, who's the chair of Health and Biomedical Informatics here at Northwestern. And it really focuses on the use of information by people. There's many kinds of informatics. Some of us think of radiology informatics or pathology informatics, clinical informatics. The domains can vary, but the methods are largely standard, and it's more of a systematic way of approaching how we use information. And so that's where I live, and I've gotten used to explaining informatics, so I try and dress it up as a cartoon. And what we're looking at here is, what is a single unit of informatics? Like, what is my unit of study as an informatics scientist? And keeping in mind that this is the research I translate. So most of this, to give away the punchline, is going to be under somewhat of a under a reality check as for COVID-19. But just to get through some of the basics of informatics research, the basic unit of and I have my little cursor here. The basic unit of informatics is a person, and that's this person right here, using information, and I have the binary here as a stand-in for any kind of information, really. It could be yes, no, it could be red, yellow, green, it could be a number, it could be almost any kind of information. And where informatics really comes in is this plus sign. It's the interaction and the delivery of the information to the person. And so, this is largely what I consider informatics methods. This plus sign is when we bring people together with information. So that leads you to what is a good informatics question, right? As an informatics scientist, what am I trying to do on a regular basis in my research? So from a research perspective, what I'm usually saying, I'm asking the question, is a user working in concert with an information resource measurably better at achieving their objectives than without the resource? And so again, we see our friend here who's using this information. But let's put that into there we go. Let's put that into an animation. And so again, we have the person using information, and we're really, this inequality is really is the notion that information can make this person's job better, faster, easier somehow, that their use of the information can improve their ability to achieve their objectives in their task or their job. And again, like I said, this could be nearly any kind of task or job. I'm a biomedical scientist, so usually it's within biomedical domains, but information flows in almost every industry. And because we're scientists, there has to be a question mark, right? We're really asking the question because we all know we can deliver lots of information, but it does not always improve people's ability to do their job, right? And that we have to be fair and objective. I don't really get an opinion as an informatics scientist of whether or not I'm improving your use of information. It's really, we have to have measurable objectives. We have to have measurably better ways. We have to be able to measure whether or not we're better at achieving our objectives or not. So we have, again, our person plus our information. And we're asking the question, are they better at achieving their objectives? And so this is largely the realm here of informatics research, asking this question. And so that's what I do in my life at the university, is I work with many colleagues in clinical units and people in my department. And we think of ways of delivering information, whether at the point of care, whether to researchers, whether to people designing clinical trials, whatnot. And then we have to be fair and ask the question, are we improving it or not? We can't have the conceit that just delivering information always makes things better, because we all know we can have information overload, we can have inaccurate information, there's timeliness of information. So it's not always a proven, we can't always say that this inequality is true. So, and that's largely what I'm trying to translate to my everyday practice for COVID-19. And so just to bring it back to public health, how does this translate to public health? Well, again, we have our friend here interacting with their information. And again, it's a question, but, largely what we're seeing these days are, let's just say, for example, time series of information, right? This is flu from a while ago, so don't try and read too much into this. We don't have 3 outbreaks of COVID-19, just 1. But, we have largely public health type information. This could be a time series of COVID cases. This could be outbreaks, many things. And, these days, almost everyone's doing public health. But even in peacetime, I do make the argument that a lot of organizations do population health, and it doesn't necessarily have to be public health. But we can imagine like an insurance company, for instance. There are users at insurance companies every day that benefit from information so that they can better achieve their objectives. Of course, hospitals. I work very closely with Northwestern Medicine, and we deliver lots of different kinds of information every day. I especially work on population health, chronic disease management, stroke ICU, many different projects. So hospitals, of course, can benefit from better information, and we can do research in that regard. What I'm doing now, I'm working with the state of Illinois, and certainly there's many people in the state of Illinois that can benefit from information and do every day. I'm an epidemiologist. It could be a bureau chief. It could be a division head. It could be the director herself. It could be the governor's office or any of the deputy governors that all benefit from, that can benefit from better information. And so largely that's what I would like to happen. That's what I would like to happen on a daily basis is that we're delivering information and we're able to ask the question, well, did that happen or not? Right? And so we're going to get to the reality of that in just a second. And lastly, let's not forget the city of Chicago, but it's very similar all the way up to the commissioner. People use information on a regular basis, and we have to ask the question, is this better? One thing, and I won't get too high up on this horse, but we also have to have, what I'm saying is a unit of information is a person, is information plus the person. And one thing we have to avoid is that where information is superior to our own intellect. Just don't think we're there yet. I have many colleagues working very hard on this, and Northwestern is a national leader in artificial intelligence, but we're just not here yet where we are subservient to the information, right? That the way we do informatics is that it's a person working with information and not the person working for the information. We don't blindly follow the advice of machines just yet. So let's talk about informatics in practice. I'm just going to start with this because I think this is actually the reality of it is. And I think that this is what I find most useful on a regular basis is that when I start to tackle an informatics problem, whether it's actually in my resource or whether it's in my everyday work on COVID, it's about people working, and it's largely finding out about their work and how information flows to them and how they use it. A lot of times it's a process, and it involves more than one kind of person, especially in healthcare. We have multidisciplinary teams. It's very collaborative, and it's becoming more collaborative every day, which personally I just love about medicine and how it's evolving. And so, informatics is largely about getting into processes and understanding the flow of information and identifying places where we can intervene. And so we can get into that, but so we're gonna talk a little bit about what are some of the common workflows and how do we get into those common workflows. This is in patient oncology, by the way. So public health surveillance is something I work on, although public health surveillance these days can mean a lot of things. So I'm going to specifically talk about a few kinds of public health surveillance. If you follow the Stephen Thacker, definition of surveillance, then why wouldn't you, honestly? Surveillance is really the collection, analysis, reporting, and response to population health information. And so, this is sort of the shorthand for the process that I'm always trying to improve, whether it's in the collection of data, whether it's in the analysis of that data, the reporting of that data. And people ask about reporting. I think that these days, this is actually where most of us live right now, is consuming other people's reports. And I think we're all aware that we could always do better in the visualization and consumption of information. And then, of course, response, which is really where the rubber meets the road. If you're getting these three things right, then you can actually formulate a response and take action. This is largely what the CDC calls information for action. And, if you're doing it the right way, this response will generate data that allows you to feed back into the process and improve it over time. Good surveillance systems improve over time, which is a natural informatics problem. of how do we improve our surveillance, how do we improve our process over time, how do we use data to get better in our work. So this is like a typical public health workflow. Where I live these days is in contact tracing. I do a lot with contact tracing. So this is just a very high level look at contact tracing, but I kind of wanted people to see the process of contact tracing and how the information flows from the various parts, and where we can see opportunities to intervene in contact tracing systems. Testing. I think that this is one place where we're all participating in contact tracing. Those of us that have needed to get tests for one reason or another. A person gets tested. Those tests are centralized, whether it's at the state or the local or the city of Chicago or some other jurisdiction. Once that flows into the state, we initiate a case, and then we push that out to the local health department, where they investigate the case, they elicit contacts, they enroll the contacts into our contact tracing system. And if they are in self-isolation or quarantine, they may need resource coordination, for 14 days or more. And this, of course, is another opportunity for us to intervene with better informatics. And so you can intervene within a process, in any one of these: better testing, better case identification, case investigation, et cetera, et cetera. You can intervene in any one of these with better informatics. Or you could take the process as a whole, and you can use the information that it's generating to deliver information to those that need to know it. So this process runs every day, unfortunately, hundreds of times, more than hundreds of times these days. And so every time it runs, it's generating data that we can use to help run our program. And so those that can be rolled up to some sort of central command structure. At IDPH, we have a central command. At the city, there's a central command structure that's largely in charge of understanding the COVID response. So that this information can be rolled up into program level metrics, which is another opportunity for informatics to affect change in better program level metrics. And then, those program level metrics can then also further be refined into jurisdiction level responses, whether centrally we make a recommendation, or the jurisdiction themselves takes action within to their constituents. And then ultimately, like I said, a really good surveillance system that will feed back and make this process better, right? And so whether we're improving our use of metrics, or whether we're learning about the outcomes of this response from the jurisdiction, whether it was successful or not as successful as they would have liked, ideally we would feed that back into this process, and we would affect change, possibly with better informatics in some part of this that would again then improve the loop, and as we spin the wheel here. How are we doing, Nori? Can we wait for questions, or are there burning questions that we might need that might need treatment now?
I think it would be great to have you go ahead and finish your examples, and then I think people are answering questions as we speak, so I'll try and direct them at the end.
Okay, great. I just want to make sure that there's no burning questions. I realize I'm going through this kind of quickly, but
I'm sure you'll be asked to come back to it.
Yeah, we'll definitely probably come back to it. Great. And so, this is a lot of how I spend my day is working on various parts of this workflow and trying to understand information, opportunities for us to, provide better information. And this is just what I'll say is the reality of this is that whether it's at the central levels, a place like IDPH or CDPH, or it's at a local health department, this is very much the research view of what it is we do every day. And there's real constraints of time and resources. We all know this. I in fact have, in 10 minutes, I'll have 3 different Zooms going in my house while my children go to school. We all have added pressure, right? We all have added things to do. And so this perfect flow chart I have here where information is flowing and we're learning and we're feeding back, we all understand that there's real constraints here, and that we may even be aware of how testing could be better, or how contact tracing could be better, or how we could write better scripts or have better data capture in our screens. We all understand that there are real constraints on our time and our resources. And even our best people don't necessarily have time to translate their insights into a well-designed informatics intervention. And sometimes we're just getting through the volume. And this is one of the things that's hardest to learn is, when I first came in, was that, you would hear the problems. And of course, me being the informatics scientist, I would break it down and I would say, well, that's an information problem, right? And that if we can deliver better information, and Nori has helped me with some of these questions in the past. If we could just deliver better information, maybe we could fix the problem. Or even maybe the conceit that we would fix the problem, which I think is even more dangerous. And I've quickly been disabused of that notion. This is where we have to balance the reality of the situation with the matters at hand, and that we're in an accelerated environment. Another thing that I learned is that very rarely, because informatics usually does take infrastructure, whether it's new system, new databases, new coding of things, training of the users, even if you do have information at hand, people need to be aware of how to use it, what the changes are, there's change management. We're almost never fixing today's problems. And the fixes that we're working on today only have a shelf life because things continue to change. And so a lot of us have really dug in to, get it right. Okay, this time we're finally going to get it right. And then that rascally pandemic goes ahead and changes, right? And things change, or the weather changes, or our behaviors change, and volume changes, and the patterns change, and there it goes, right? Our informatics shelf life has already been reached, and we have to be more nimble. And so, for me, it's not that I stopped trying to fix things with informatics, but I did realize that understanding information flow in and of itself can be an intervention, and not necessarily building something, and certainly not necessarily setting up a design that allows me to ask the question, are we measurably better? And organizing whether it's a descriptive study, a correlational study. Lord forbid I tried to do a trial in the middle of all of this. Especially an informatics trial. I think we're going to have to come up with other trials in the near future, but there just isn't time for that, right? And so this is the real crux of the translational issue of the informatics scientist that sits, in the university, and we write grants where we have 3 to 5 years to execute on a very well-written question. I'll just say, just this morning, 6 minutes before someone was going to walk into the governor's office, we had to fix an information issue. Right? And so sometimes we have a 6-minute deadline. If we're lucky, we might have a 6-hour deadline. Sometimes we have 6-day deadlines, but we certainly don't have 6-month or 6-year deadlines. And so a lot of these interventions, when we're working through really complex processes, and I'll just say that, a central command can be 50, 60, 100, 200 people working together in a completely decentralized environment. I'm sure we're all living on our Teams or our Slack or our collaborative environments. And this is 97 jurisdictions across the state, right, in 103 counties. So, standardizing in informatics intervention across a process like this is really challenging. And, I give all the credit in the world to state agencies like IDPH, but many of the state agencies have stood up technologies and solutions that have had to be rolled out statewide. And, one of the things I've learned is the vast diversity of peoples and places and cultures and and resources and across the state makes this very challenging. And so while I know as an informatics scientist what research would dictate and what in a perfect world, in a vacuum, what I would do, working on something like this really makes it challenging. And so I'll just take a couple more minutes here and talk about resource coordination, just as kind of a little bit of a mousetrap. If you notice up here, I said, if a case needs it, we might coordinate resources. and how that actually turns into information. It's kind of a laborious process, but healthcare, I think, is very familiar with identifying a patient that has a thing, registering them in some sort of panel, and then assessing their condition and then following them over time. This is a fairly common, whether it's for diabetes or a heart cardiovascular condition. This is something we do every day in healthcare. And in fact, there's many Northwestern scientists that are very good at improving these processes. And as we follow people over time, they generate outcomes. Ideally, everyone would get better, but we know not everyone gets better. And so, those outcomes turn into a series of outcomes that we can report on and that we can count up, and then they can be summarized, let's say by an epidemiologist. So this would just be one information flow within one of those boxes, resource coordination. And so in my mind, I'm thinking, how can I break this down into these little parts? When most people are just trying to get their arms around the entire process. And so if you think about this summarization, a lot of times this becomes a calculated metric that people rely on. So fantastic, we have a meaningful calculated metric, but the truth of it is what my training has taught me, and this is one of the hardest things for me to separate myself from, is that once you have a calculated metric, you have a calculated metric, and it has a life of its own, right? And we all know that the data that's input into this calculated metric, I could write a whole paper just on the input into any one calculated metric. And in fact, I think as a university, we have many of these papers, just the input into calculated metrics, right? And I think Nori is an epidemiologist shaking head because as a population health scientist, she let's just say takes advantage of many different inputs. The actual output that comes out of that calculated metric, whether it's a dashboard, whether it's some indicator, whether it's a risk score, whether it's a propensity, whatever it is, I know that there's a lot of considerations for what that output is. All of us that are generating calculated metrics right now, we dream that our users are taking some kind of action, right? That we've spent all this time standing up this meaningful process. We've made the process very good. We're outputting the best possible metric. And what we would love is if our users took action, whether they picked up the phone, whether they did an investigation, whether they, allocated a resource, whatever it is, right? And we could always be asking, is that action appropriate for the metric that's being generated, right? Can they actually take an action? Human judgment, well, the number says I do X, but I know from 20 years of doing X, I'm not going to do X today, no matter what that metric says, right? And what we would love to do is be able to take the time to incorporate human judgment into our metrics, right? This is another luxury that very rarely we have these days, is that the dashboard says we do this, right? And unfortunately, we're living in a world of thresholds right now, whether it's school threshold, whether it's restaurant threshold, whatever it is, right? And when we reach the threshold, something good could happen, but more often something bad could happen. We would love to be able to exercise human judgment. We would love to be able to systematize how we exercise human judgment and whether human judgment is affecting positively that metric. Measurable outcomes, we would love to know if taking the actions are leading to measurable outcomes and whether or not those are successful or failures. Successful, or let's just say not successful, right? So the use of this calculated metric leads to measurable outcomes. What we would love to do is understand, when a person uses my metric, did it work? Did it not work? And turn that into data, right? Because ideally what we want is a system that learns. And again, this is just one metric from one box, from one process that I showed you. And we could do this for any of the boxes, right? Is we would love to learn whether or not our metrics are actually making a difference. Turn that into data in which we could then feedback and train our metrics further, right? We would love to be able to, some of us do machine learning, some of us do modeling. We would love to be able to train our models on the success of our models, not just the inputs and making the inputs good, but how well our models are behaving, right? Did we get it right or not? Are our forecasts accurate? Are our risk scores being helpful? Are the people really benefiting from our models? And so, we would love to be able to put together data appropriate for learning data sets, which then we could use to train our models and feed back into the calculated metrics. and so, oh, sorry, I was supposed to hit that. So that's really all I have. And it's really to reveal like it isn't actually to say that I have the answer. It's the exact opposite. It's that most likely most days I don't have any of those answers. I do understand the very basics of my discipline and my science, just from years of doing it and working with excellent colleagues on different projects. Unfortunately, this is really the tragedy of our professional lives, is that we know how it usually works. And we would love to be exercising, 100% of our capabilities in all of these problems. But the truth is that as an informatics scientist, I just have to do what comes up next. And sometimes I get to do some parts of this when time allows, when it really is going to make a difference. But for the most part, if I get to do one part of this, once a week, I feel like it's a really big win. I think we can all afford to give ourselves a little bit of slack, and this is supposed to be a translational talk. And I think that largely is my message, is that, man, I wish the informatics that I practice every day in the university was able to translate to my public health practice. But the truth of it is that we all have trade-offs. So that's where I'm going to leave it. I wanted to leave at least half the talk for questions and answers. Sometimes answers. I know there's going to be a lot of good questions. So if I don't exactly answer your question, I apologize. But these days, being an epidemiologist is somewhat being of a soothsayer and sage, that I do definitely get questions that I don't know the answer to, and I'll be the first one to admit it when I don't. So,
well, there definitely are a lot of questions. So
I don't know if that's good news or bad news, Nori.
I think it's great news. I think it's great news. And I think I really appreciate the overview and the acknowledgement of the complexity and where informatics can really intervene with public health. I'm going to ask a kind of broad question first, and then I'll kind of dig into the detailed questions. But you ended on a topic that I was going to ask you a bit more about, was whether you think this pandemic has really opened the doors or opened the eyes of public health officials about the value of an informatics infrastructure and what it can really do to preserve public health, especially in the time of pandemic, but hopefully all of the time.
That's an excellent question. But it's kind of it's a nuanced answer. I think the answer is actually no, because they knew this. We knew that our public health infrastructure could benefit from better informatics infrastructure, whether it's surveillance systems, whether it's registries, whether it's tracking how we vaccinate, whether it's social media and communications and outreach. Across the board, we've known for some time now that public health has been underfunded. And that comes out in many ways. It's not just informatics. It's a lot of there's many ways which we could do better in public health. But yeah, I think that one thing that I see that is really heartening is the reliance on daily information, minute by minute information of people making decisions, and really, some of the dedicated people. I think the people that I think where I see it the most is it's 50-50. It's information, but it's expertise, right? And what I see is people really appreciate the informatics infrastructure that we're growing. That leads to a lot of these metrics that we're using every day, whether it's deduplicating tests or the flow of contact tracing information from one place to another, whether it's delivery of vaccines to the right, neighborhood, all of these things. But I think that it's exactly what I said. I think that people appreciate information plus expertise. When a person says, here's our dashboard, it's a very good dashboard, but I'm here to tell you that you have to take this number with a grain of salt, or with I'm a human footnote, right? A lot of times we serve as human footnotes to our own metrics, where it's information, but it's advice. And I love the interplay. I love the interplay that we're certainly not slaves to metrics, which is easy to do when we put too much faith in our new informatics infrastructure. But what we're learning is the interplay between expertise and information, which I think is so valuable. And that is really, to me, an evolution that I've just seen happen over the last 6 months.
Well, it sounds like it's good to see that evolving. Hopefully there's newfound appreciation for the underfunding of our public health system. More questions came in detail about the contact tracing and the information systems that have been set up around that. So one of them was asking about, considering the information flows that you show for contact tracing, how do you think informatics changed the contact tracing process? Did it aid in understanding or change or improve the process?
Well, my pat answer is that contact tracing has been around for a long time. And,
did it make it more efficient?
It made the documentation of it more efficient, right? And that, to be fair, contact tracing is a very complex process. And that, you know, one of my favorite informatics, you know, scientists said, keep in mind, we're swapping out our entire surveillance infrastructure in the middle of a pandemic. Right, and the chances of us getting it just right, especially with the target is moving, right? The target is moving is really unlikely, and so I do see a lot of efficiencies. Some of them are very simple. Some of them are very simple efficiencies where it's just easier to, for instance, track down an address. You know, if you can pull in someone's address from a Google API, or if you can, you know, match a contact to a case, you know, it doesn't have to be a manual process. So some of the software has made it much easier to move information around, especially for case investigations and the actual contact tracing itself, which, you know, is largely a manual process previously. We never had this volume. You know, this is like a year's volume for a lot of places, or a week's volume, you know, in a single hour. So where they could get along with manual processes, now we have a system. So in some places, it's just there was nothing, or there was something very simple. And so this ramp up in volume that we've had definitely is a benefit. And then, you know, just the use of the information is getting better and better every day, that we're able to benefit. You know, for a while there, we were understanding our capacity to do contact tracing. So it may not seem obvious, but when you have lots of people using the system, you know how many people are tracing cases, right? How many people are actively tracing cases. And this, in the beginning of the pandemic, was one of the key metrics was, well, how many contact tracers do we have, right? So there's a couple ways you can do that. You can survey the entire state and ask every jurisdiction, how many contact tracers do they have, right? And knowing that there's other contact tracing happening out in the community, so have somewhat of an unsatisfactory number. Or you can actually look at the logs of our systems and see active tracing happening, just like in electronic health record, you could see active care being developed, right? I mean, not developed, but delivered. And so in some ways, you know, some of the tricks I use in my own work at Northwestern, I've been able to use for, you know, in some of my work in contact tracing, is that understanding how many active tracers we have on any one given day, some of the metrics around productivity and some of the metrics around how efficient we are being, you know, those help us run better programs. And I think we've gotten better at those. And now where we can get to is better and better refinement of epidemiologic information, like locations and demographics and things like this, where before we wouldn't have had that standardization. So I think it's better in a lot of ways, and we've really benefited from these systems.
That's good to hear. And in fact, there's actually been a couple of our attendees who are certified contact tracers who have volunteered their expertise. So.
Not gonna lie, I know a couple of them personally. They're on this call.
Good. Well, there's more interested, so I hope that there's opportunities for them to get involved as well. Just as a follow-up, so I would assume not only in efficiency, but it maybe there's a more integrated approach in terms of jurisdictions across the state. There was a question about whether the contact tracing databases are actually shared across jurisdictions and kind of under what circumstances, but does the informatics allow for a more coordinated approach on, let's say, a state level?
Oh, absolutely. But, you know, one thing I would say is that the state has excellent informatics, you know, resources, albeit, you know, strapped like everyone else is for you know, for time and resources, like we all are. But I would just say that it is a statewide system. And so one, you have a cadre of people centrally that are coordinating the development of a system, but it's, you know, because we are, maybe I didn't explain this, but, you know, Illinois is a home rule state. And so our 97 health departments actually have quite a bit of autonomy, and that they make most of their own decisions, you know, and a lot of what is done centrally is advisory and guidance, but the actual health departments make their own, you know, they trace their own cases, they make their own decisions. And so from the very beginning, there was an understanding that the system would be developed with the jurisdictions. And, you know, of course, with 97, you know, can you imagine, you know, 97 hospitals participating in the design of electronic health record, for instance, right? Like there are some trade-offs. You can't necessarily, especially in the middle of a pandemic, get every single voice at the table. But I think that, you know, having a participatory design and you know, nimble developers, an army of consultants and resources of people that could help to channel that into a build. I think that, number one, to answer your question, it is a central database for the 97 jurisdictions. Chicago does have their own because they're a separate thing and receive separate funding. But for the most part, most counties are operating off of the same database, but it's reflecting their own tracing. And a lot of it is also was developed and continues to be enhanced with their feedback in regular meetings and contact with the jurisdictions. It's actually phenomenal to see, and we've talked to other jurisdictions about how we run this, you know, 103 county, 97 health department, you know, decentralized system. It's really a marvel to see the progress that we've made. It does make challenging things for like standardization, and you can imagine database design do benefit from standards and central coding systems. And so sometimes that's a little bit thwarted, but for the most part, you can get a strong signal out of 97 health departments.
Yeah. So following up on that, so obviously I'm a researcher and you are coming from a research university to a public health department. Do you see a joint role of research and public health practice that can inform each other? And is informatics a solution to help integrate those two things, or is really all hands on deck for just the public health practice component of that?
No, absolutely. I mean, just personally, my informatics will never be the same again, right? Like just personally, you know, and it's, you know, just to share a personal reflection, you know, like I've worked in the stroke ICU with researchers, and you know, that's largely an acute situation. And I've also worked with the MI, the myocardial infarction group, in cardiology, and it's a crisis situation. And as the informatics scientist, of course, you hear that, you understand that you're in a healthcare environment. But as an epidemiologist, you know, like this is my crisis situation, that it's been a while, you know, since H1N1, it's been a while. And so working under those conditions and understanding the stress and intensity of the experience has really changed. But I think to more broadly answer your question, I would love to see a better feedback loop between practice to research, but then also research back to practice, that we can't afford to just practice and not throw off data that can go back to research, right? And so we can't just say, oh, you know, researchers are operating in a vacuum, and that they're two separate things, right? I think that we realize, and I think Northwestern has done as well as anyone in pivoting their research to COVID. I think even, you know, like just budget-wise, I think that we've done quite a bit to pivot our research to COVID-19. But that's largely taking our own research and pivoting it towards COVID-19. What I would love to see is public health practice data feeds back to the research community and seeds new, you know, I think that as far as innovation and breakthrough science, team science, and large research projects, Northwestern is one of the best. And I would love to see public health practice data turn into research opportunities where we can learn and be nimble. But I think it goes both ways. We can't afford to not incorporate what the researchers are saying. We can't just, you know, turn a blind eye like I've got a job to do. and also as public health practitioners, with a little bit of thoughtfulness and some collaboration, we can turn data back to the research community, and I think incorporate them as part of the team. You know, just thinking out loud, having a research team as part of the public health practice team is not a bad idea, even if it's simply for publication and communication of what we're finding in every day. I think we could always do better, you know, in getting the word out. I've heard many things about, you know, science in the time of COVID-19, but, you know, researchers are professional, you know, publishers essentially of scientific evidence, and that shouldn't be any difference now, right? And so maybe we do better in public health practice to incorporate researchers into the team, and vice versa. So I do see that there is a feedback loop there that we could build.
Yeah, I think that sharing of information back in both directions is really important. So there was a question on translational applications can lead to new approaches for prevention, diagnosis, or treatments. However, we don't always see widespread adoption and implementation of them. What advised public health practices have you seen that fall into a later adoption, or has early adoption not been a problem given the severity of COVID-19?
I'll make it an informatics problem. I think that as far as adoption of any of this implementation, you know, we do a lot with implementation science at Northwestern, and informatics is a big part of that. I think we could do better at trying to understand the people we're trying to extend the technology or the informatics or the solution to, and a better job of listening and systematically listening to what does the community need. And one of the informatics opportunities that I see is structuring those conversations. When we get feedback from the community, I think both CDPH and IDPH are excellent at talking to the community and listening to the community. But we can do a better job in turning that into knowledge. And I really mean computable knowledge. You know, is the dialogue, you know, is the dialogue about social determinants of health? Is the dialogue about access to care? And can we actually turn that into structured information that feeds back, you know, whether it feeds a better social media campaign, whether it feeds back a better database design? Can we take what we learn from the community and structure it in such a way that it benefits future implementations and future technologies that are extended to the community for adoption? And this is one of the things that personally I'm most interested in, is learning from the community what we don't know and what is the conversation, and turning it into knowledge such that it can fuel a lot of different interventions. And so that's largely what we're talking about, is public health interventions, and making them smarter means that they need to be, knowledge needs to be delivered in a computable way, just like that graph that I was showing way back when, that, you know, we need to be able to learn from our successes and our failures. And without computable knowledge, that's really tough. So when we try and extend something into the community and they tell us why it's not working, there's excellent qualitative research, right? There is excellent qualitative research out there, and we can learn from that. But as the informatics scientist, I want it to be computable. I want a mixed methods where not only do we have the conversation and we systematically learn, but we also turn it into computable knowledge. So if aggravation of diabetes in the community is the issue, understanding that there is a code, you know, for diabetes, and that there's intensities for diabetes, and that there's diabetes stored in databases about people for resource coordination, and et cetera, right? We can turn it into knowledge. So implementation and adoption is hard. I'd like to make it a tiny bit harder and turn it into a dialogue to understand our success and failures, so that we have computable knowledge that makes things better in the future as we move forward. And I just think that we're getting to the place now where we are starting to talk to everybody, and it's a kind of a wasted informatics opportunity not to turn that into computable knowledge.
Yeah. Yeah, I think there was a specific question that maybe is relevant to that discussion about computable knowledge, but also the research practice loop. So the attendee asked about the NM system has a large effort to abstract clinical data into IDPH INEDSS data system from EHR. How does Illinois use these clinical informatics from public health efforts and inform local and state decision makers? How does that data coming back into the Department of Public Health actually change the practice of public health?
You could just take a really simple example. This isn't necessarily an IDPH specific example, but the most basic, let's just talk about bed count, right? There's many systems for bed count, and this is really important for every state that we have utilization of healthcare resources as one of our key indicators, because when our resources are overrun, we have to change what we do, right? And something as simple as bed count stood up as a siloed system that's estranged from our clinical systems is not going to be as accurate. We're not going to understand the use of our healthcare resources if it comes from, let's just take like a ridiculous example of a person walking down a hallway with one of these, a clipboard, right? And counting beds, right? We could do it that way, and we would centralize that and send it, right? Some of the systems are about that sophisticated, right? But we know that we actually have living, breathing electronic health records that can be queried, and we can understand exactly who's using the beds and what they're being used for. If you really understand utilization and you understand who's utilizing those the bed and the census, you can make better decisions, more precise decisions. People have talked about precision public health. Good idea, I guess. we're not quite there, but you can be more precise in how you use your resource utilization, right? So, I think that one opportunity we could have is just better census, for instance, and feeding that back to the decision makers that could fine tune some of the crude thresholds we use for, closing, or closing or mitigation or whatever it happens to be.
Mm-hmm. Yeah, I think that's the other loop, is making sure that there's changes or interventions based on the data that's found, and that's a really important thing.
I would love to use the clinical data. I'm sorry, but I would love to get into the clinical data. I think we're not there yet, to be honest. So I did kind of not answer the question. I realize that, but there could be uses for the clinical information. I see resource coordination as a really big one. And the other part of this is that we're not done yet. And one thing that I've said since the beginning is a COVID infection does not end at a negative test. And I think that many of us are aware, I'm sorry, there's always landscaping during the biggest talks. I think that if we consider a person recovered at the end of their infection, I think it's really short-sighted. And where a lot of the clinical information, the clinical integration, I think is going to really be most useful is understanding the real cost to people and populations over time. And I think that this is an area where you also have great interest, is that recovery could be 2 weeks, it could be 2 months, it could be 2 years. For example, I was at the New York City Department of Health for a long time. The World Trade Center registry still is going. We still have a World Trade Center registry. We're still learning about that event, the cost of that event, the toll to human lives, right? We may get to a place, and I think we will get to a place where COVID registries are incredibly important. So just because we can't use the clinical data today, I don't think that means we're not going to use the clinical data. I mean, we use testing data. We do use clinical data in several ways. But I think that really getting into the clinical data is going to come when we really try and understand
those long-term.
What just happened here. And for years to come, I think we'll be trying to figure that out. And electronic health records, clinical integration is going to be a big part of that.
Yeah, this is definitely going to be a long-term strategy. So I was excited when you shared the news that you're going to be moving to CDPH and some of the new responsibilities you'll have there. So I thought that this would be a perfect way to kind of wrap up the rest of the talk and think about what are the information informatics strategies you envision for CDPH, definitely in the era of COVID, but also even longer term. What are these long-term health consequences, long-term chronic disease health in Chicago, and how can informatics really address some of the issues and challenges that are facing Chicago?
Sure. I'm going to spare you guys the lawnmower.
I think we've all had to deal with that. So.
Murphy's Law. After all, I am human. And let's just pretend that there's peace and tranquility on the screen. Can you all still hear me?
Yep, we can still
Okay,
hear
great.
you.
Yeah, hopefully there's less lawnmower too. Well, I'll just say there's tremendous opportunity. You know, when I was training as an epidemiologist at the University of Pittsburgh, that first chapter, John Snow, the pump handle, we all know it as like trained epidemiologists. I never got off that chapter. That was always the epidemiology I wanted to do, was surveillance, outbreak, cluster detection. And really, like, I found that to be like public health superhero stuff that I always wanted to do. So when I was trying to do my research at the University of Pittsburgh, they're very good at clinical trials, cohort studies, but I needed really a health department. So I went to the city of New York. Just after, I went in about 2005, and it was still in the shadow of 9/11. And it was really this transformative opportunity to, of course, we wanted safety and security, and hospitals were more willing than ever to share data. And of course, like, there was a posture of, we have to be prepared, of preparedness, and we had terrible events like anthrax and things like this, but it was an unprecedented evolution of public health. There was and so there was Take Care New York, which this was the city's health policy from Dr. Frieden, who was the commissioner at the time. And what we largely did was we took that clinical integration from this terrible event. And what we did was we took that integration and we turned it into chronic disease trending in the 5 boroughs, and that largely supported Take Care New York. I never thought I would be in this situation again. Fast forward however many years now, we have another public health catastrophe. We have political will and we have momentum in a way that we never have before. I see this as a second once in a lifetime opportunity to evolve public health. And one of the things that really most attracted me to the opportunity to work with CDPH, other than it's a fantastic public health department, was that we have Healthy Chicago 2025 on the horizon. And that, the prevention of the spread of coronavirus, is a hard problem, but so is diabetes, and so is suicide prevention, and so is lead in homes, and all of the indicators we track as a city. And so what I'm most excited about is aligning solutions for today with what we need to do to get to 2025 in Healthy Chicago. And really, whether it's whether it's better clinical integration, which I think is on the horizon, whether it's things like better analytics, maybe we move the analytics to the cloud, maybe we're able to get better use of information, whether it's fantastic contact tracing infrastructure. Let's not forget, STDs have been killing Illinois for a long time now. We had seen unprecedented levels of STDs for a long time now. STDs are never going to be the same again because of our contact tracing infrastructure. So I'm looking forward to making public health progress, right? My informatics dream, and I think that this is, I think this is a dream at CDPH too, is to build the perfect prevention machine. How do we build the perfect prevention machine? We're not going to get it right, of course. There is no such thing. It's sort of an academic exercise, but how do we build the perfect prevention machine that not only takes care of coronavirus, but also is forward thinking and helps us reach all of our goals, whether it's chronic disease, whether it's social, behavioral, and we take care of everybody, right? And so really my past experience really informs, hopefully what we do moving forward. And I don't want to give up on 2020, but I take comfort from 2025 that it makes 2020 worth it. And I think a lot of us are in that boat right now. So I hope that answers the question.
Yeah, no, I think I want to say thank you so much for sharing and ending on that kind of vision of where we're going to go. I think that's a silver lining to the situation we find ourselves in. So thank you again for sharing your experiences and obviously vision going forward. And we appreciate all the attendees for joining us. Thank you so much.
Yeah, thanks everybody.